a farm owner. Great. And she is going to be our moderator for today's program. She is an advocate, and I can say personally, an advocate for breast health equity, an expert. She serves on the faculty of several well-known universities, and it's my pleasure to introduce Dr. Mo. After that, we'll have some meet and greet.
Wow. Well, thank you for that. I'm going to give you an updated bio because there are some wonderful breast surgeons in the state of Pennsylvania now, and I am not the only one, and it should not even be that way. But I wish there were more than single digits. So we have a lot of work to do on the subject of health equity. And I think that this talk today, this conversation, because that's really what it is, it's a curated conversation where all of you can bring your questions, bring your stories, your lived experience, and participate in ongoing dialogue with some action items, hopefully, for what you can do to move the needle as well toward health equity in the breast cancer space. So it's a privilege and an honor to be here to share this panel with these amazing speakers that I'm going to introduce in a minute. And let me just give you a preview of what is coming up, right? Because we're doing this every fourth Saturday. You find it not robbery to join us and to tune into these topics. And so next month is juicy. Navigating sexual health after menopause, navigating sexual health through a breast cancer journey. We hope you come back. We hope you invite a friend. We hope you bring your questions, and really let's prepare to get into some subjects that are going to help you throughout the year. But today is a really foundational one. We're talking about Black genes and why they matter. I mean, even what are Black genes, right? Like, and do they matter? I mean, we think they do, but are your genes any different than anybody else's genes? Was your cancer any different than anybody else's breast cancer? Do you know? Do any of us know? And so we have folks who are going to talk to us about this today. We have the experts here, and it's my privilege to really introduce them. I want to thank our sponsors, of course, Hologic, Myriad Genetics, High Impact Partners, the Vassar Center for BRCA Health, and we're going to do some giveaways like we talked about. So I think the first thing I want to do is I want to make this interactive, and I want to let's do an icebreaker, right? And so before we get started with this session, we're going to break out into some breakout groups. And it's snowing in Jersey City. I do not love it. Let me just disclaimer, I don't love the snow, even though I'm from Pennsylvania. But I want to know, what's your favorite season and why? So we're going to go into are we doing breakout groups, Laura? You're on mute.
Not today. It's a webinar, which doesn't allow us to do breakouts. And we have such a packed agenda with these experts that we didn't quite have enough time for our traditional breakouts this time, but they'll return.
Fantastic. Well, we're going to invite you to put in the chat, and we're going to have a couple people maybe raise their hands and let our panelists share. But what's your favorite season, Laura?
I have to say my favorite season usually is summer, but I'm falling in love with fall a little bit. I don't like to be cold, period. Anybody who knows me knows I could probably wear flannel pajamas year round. But I like the summer because it's nice and hot, no jacket, very flexible. That's my favorite season.
Dr. Maya, what's your favorite season?
I am all things fall. I am a basic fall person. Apple, pumpkin, the whole 9 yards. I love blazer weather, wearing some boots. That is, love seeing the leaves change. That's my favorite time of year. Not too hot, not too cold, too.
I love it. I love it. We got Misha McAllister on the line. Misha, what's your favorite season?
Mine is absolutely summer, unequivocally. Like that, I probably should relocate somewhere. Because yeah, summer is just, I love just when you step outside, you don't have to worry about what you're wearing, you don't have to bundle up. It's just, it makes life so much easier. I love the summer.
Wow. Awesome. Dr. Joanne, what's your favorite season of the year?
For me, it's fall. I might be biased because I was born in fall, but I love to hike, and that's when the weather is perfect for hiking. And I like pumpkin spice lattes, all things pumpkin. like Maya said. So definitely fall for me. Also the swag, the clothes you get to wear. So
Yeah, good boots and blazers weather. This is true. Ashley Dedmon, how you doing?
Doing good. How are you, Dr. Mo?
Magical. What's your favorite season?
I'm right there with fall too. I'm an October baby, so I love just the boots and the sweaters, the warm apple cider, and just to see the leaves change colors. So that's my season, and I'm sticking to it.
I am in agreement. I think 4 out of 5 panelists agree that fall is our favorite season. And for me, who knew how beautiful it would be to let go and to transition and to change, right? Like that can be a beautiful season in life, plus the colors and the fashion and the food. I am very, it's my favorite. So now I want to move toward our first segment. I want to introduce Dr. Maya Roberson. Dr. Maya Roberson is an assistant professor of health policy currently at the Vanderbilt University School of Medicine. And she's talking about how we got us striving toward cancer care equity for Black women with breast cancer. Her research interests are in applying epidemiologic methods to health services research to promote health equity using big data sets for Black people in the Southern United States. And she is the principal investigator or the chief investigator for research and a career development award entitled Centering Equity in Hereditary Breast and Ovarian Cancer Genetic Testing, a mixed method study funded by the American Association for Cancer Research in partnership with Victoria's Secret and Pelotonia. Roberson earned a bachelor's degree in public health from Brown University and a master's and doctoral degrees in epidemiology from UNC Gillings School of Public Health, where she was a Robert Wood Johnson Foundation Health Policy Research Scholar and a Truman Scholar. And she is truly, as Laura said, she is truly a badass. So we're going to enjoy the presentation, jot down your questions in the chat because we will have time for a Q&A. But we got to talk about how we got us, Dr. Maya. Welcome.
We do. Thank you so much, Dr. Mo, for that introduction. Next 2 slides, please. And one after that. So before diving into how we got us, I think we need to talk a little bit about how we are not, Black women have not been centered, Black people have not been centered in how cancer research is fundamentally conducted in the United States. And this has led to a lot of the issues that we see today. I would go so far to say as that the conduct of cancer research has historically been structurally racist. We have not been foundationally included in research that has been done that has had ripple effects through what we know about cancer today, in particular related to cancer genetics. Next. And so there's a lot going on in this slide, but I want to just very briefly walk through about how this can kind of have implications for how we think about cancer research. And so putting on a lens of what some scholars call of race consciousness and thinking about how our own racial identities as Black women and the process of racism in society goes on to shape how cancer research is conducted. And thinking about how the contemporary patterns of race relations affects cancer research. And so in the popular media, I am sure all of us have been seeing the legislation that's been happening across the United States, particularly in the Southeastern United States, related to book bans, changing of curricula related to the teaching of racism and slavery and things like that. And you may think that that has absolutely nothing to do with cancer research, but I implore you that it actually does. Because when we see these issues and these political landscape of Black folks quite literally being written out of history, that has profound impacts for how we think about scientific discovery that goes on to shape the actual knowledge that is being generated about cancer in box 2. Moving on to box 3, thinking about how we even think about what racial identity means and how that can go on to affect cancer outcomes. And then moving to box 4 into action, thinking about, okay, we know that cancer research is structurally racist. Society can be structurally racist, particularly in this current climate that we're living in. What can we do to mitigate these harms that are being done? And so one particular focus of my research that I'm going to be talking about today is how do we think about how our new cancer innovations can get to all folks, specifically including Black women, where we know folks have not been reached for our latest cancer-related technologies and what has been learned. Next slide, please. And so those kind of big, high-level pie in the sky, you might be wondering, Dr. Maya, what are you talking about? How does this have any kind of real-world implication as it relates to cancer and our understanding about cancer? But there are profound societal consequences from the existence of structural racism that go on to affect, as I mentioned, what we know about cancer and specifically cancer-related genetics. Next slide, please. And so this is a news article that had come out several years ago that had described that Black women have higher rates of abnormal BRCA genes than was previously understood. And you may be at least kind of tacitly familiar with BRCA genes. These are the genes that can substantially increase the risk of developing breast cancer. That my colleagues Ashley and Dr. Ivory will be digging much deeper into a little bit later today. But these genes help us understand folks' risk for developing breast cancer. And when people have breast cancer, it can help shape treatment related recommendations. However, when these genes were discovered, it was only white people who were sampled in those populations. And so because of that, it was previously thought that only white people had these mutations that could then go on to lead to higher risk of developing breast cancer. And so now that we know that, of course, Black women also have these mutations, we are playing catch up and trying to make sure that Black women get the right care that's appropriate for them, given that they were not originally included at the outset. And so I wanted to set the stage for how this fundamental exclusion of Black women has led to pretty deep implications today that I know my colleagues will dig a little bit deeper into the details in their later presentations. But I wanted to start with that because I think it's important history and also contemporary patterns in where we are. And so now I want to flip it into the title of my talk about how we got us and tell you a little bit about some of the work that I've been doing that specifically centers Black women. Next slide, please. And so just important, very high level overview about breast cancer genetics. It's a very fluid, changing landscape. And so presently, all women diagnosed with breast cancer under the age of 50 are recommended for germline testing. And what that means is receiving a genetic test that helps people understand if they have a type of breast cancer that runs in their families. And so these are the things like the BRCA genes that I was referencing in the earlier slide, and also some additional genes also implicated in breast cancer. And so previously, in previous versions of these sorts of guidelines that are put out by major cancer institutions, there were all sorts of complicated combinations that folks needed to have to be eligible for testing. They needed to have a certain amount of family history of breast cancer, plus being diagnosed at a certain age and things of that nature. It could be very confusing about who even needed testing. Now, and in particular, this has pretty important implications because of how young Black women are frequently diagnosed with breast cancer. All women under the age of 50 who have breast cancer are now recommended for this testing. So it's a pretty wide recommendation. Next slide, please. Back one. Thanks. And so in this particular work that I will be walking you briefly through, we wanted to ask the question, among a cohort of young Black women, specifically only Black women who have breast cancer, how does their genetic carrier status, so whether they have a BRCA mutation or not, influence the treatment that they received? Next slide. And so this would use data from the BEST study, which sampled women, Black women with breast cancer from the states of Florida and Tennessee. And the overall goal of the study was to evaluate genetic and non-genetic factors associated with breast cancer specific survival. In this study, there's been a robust amount of data collected from Black women with self-report sorts of surveys about their general experiences with their cancer care, detailed family history of cancer care, information about the sorts of genetic testing that they may or may not have received. And importantly, I won't be presenting on this piece of the work today, but these women who enrolled in the study but had not received genetic testing at enrollment were then given genetic testing and counseled on their results following their enrollment into the study. So this study in itself also greatly increased access in genetic testing. Next slide, please. And so here we looked at 3 different groups of women. We looked at women who at baseline at enrollment into the study did not receive genetic testing. We looked at women who received genetic testing, but did not have a mutation. So they had received this testing, but were not found to be a BRCA carrier or things of that nature. And then we found, we had a 3rd group of women who were tested and were BRCA carriers. And here we were interested in looking at which of these groups that women fall into influence the treatment that they received in terms of the type of surgery, whether they had a bilateral mastectomy or breast conserving surgery, chemotherapy, and their radiation, with the idea that people who have BRCA mutations and certain other breast cancer genetic mutations are typically treated more aggressively to prevent their cancer from coming back, and also because BRCA is associated with more aggressive cancers. However, people who don't have these mutations may benefit from slightly scaled back treatment, may not need to have as much chemotherapy, may not need to get both breasts removed and things of that nature. And so the study was really looking at, are Black women in each of these groups getting appropriate treatment given their genetic risk profile? Next slide, please. And so this particular study included 608 Black women. Most of them, perhaps not surprisingly to any of us, did not receive genetic testing. 40% of them received genetic testing, but did not have a BRCA mutation. And around 11% of the women included in the study were tested and did have a BRCA mutation and should have received the most aggressive forms of treatment. Next slide, please. And so that we found for surgery, here shown in the figure on the right, that women who were tested and had BRCA mutations seen in the top figure were much more likely to receive a bilateral mastectomy, which is depicted in the cream bar on the right. Women who were not tested and women who did not have mutations were much more likely to have either the affected breast removed or breast conserving surgery, indicating potentially appropriate treatment for these patients. So women who had these mutations were much more likely to be treated aggressively per guidelines for this care. And so this actually gives a lot of hope that women were being treated appropriately for the type of mutation that they did or did not have. Next slide, please. We saw very similar results for chemotherapy, where in the orange bars, we see the percentage of patients in these groups that received chemotherapy or not. And so those women who were BRCA carriers were much more likely to receive chemotherapy compared to those who were not carriers or did not receive testing. Again, another indication that actually in this particular space, these Black women were being treated appropriately for the type of mutation that they had. Next slide, please. And we saw no differences for radiation, which is not surprising, especially given the high number of women who had bilateral mastectomies who were BRCA carriers. And again, like further hitting home the point that these Black women were being treated appropriately given their genetic profile. And so in cancer health equity, we talk a lot about disparities and equities and gaps, which are pretty fundamentally important. But I think it's also deeply important to learn from spaces where there are not inequities, where people are receiving appropriate care. And so thinking about this theme of we got us, thinking about how can we learn from where people are being treated well and receiving the type of breast cancer care that they should get. What can we learn from that, as opposed to always fixating on where the gaps are? Not saying that that's not important, but there's a lot to learn from pulling these examples of where folks are being treated well. Next slide, please. And so in summary, there have been gaps in assessing post-genetic testing care, really understanding whether people are being treated appropriately or not. And in our study, we actually found that Black women who were tested but not carriers had similar treatment than those who were tested, than those who were not tested. And so those who had mutations were much more likely to receive the care that they should have. Next. And so just very briefly, wanted to touch a little bit on why Black women had decided to pursue genetic testing, as that was another element of this study. Among the proportion who did receive genetic testing, they were asked why they decided to pursue genetic testing, and we wanted to look a little bit into their reasoning. Next slide. And so here we use the same data set of Black women who were recruited with breast cancer, recruited from the state of Tennessee and Florida. And we focused on a smaller number of women who had received genetic testing and also had information about why they decided to receive testing or not. And they, in the particular survey that these women were given, they were asked why they had received testing, and the response options included things like to guide their surgery decisions, to guide their radiation decisions, to guide their chemo decisions, or to benefit family. And so here we had combined several of the groups, the first three groups, to talk about, did they use undergo genetic testing to guide treatment or to benefit family, or a combination of both. Next slide, please. And so here we had found, if you could advance to, please. Thanks. Here we had found that the vast majority of women included had indicated that they had wanted to receive genetic testing to benefit family, either in combination with treatment or on its own. A small minority of women had indicated that they had received genetic testing to guide their treatment decisions. And I think that it's deeply important to learn from this. In the top right-hand figure, we see that this is especially important and prominent for women who had daughters. They were much more likely, as seen by the purple arrow on the right-hand side, that women who had daughters were much more likely to say that they had wanted to receive genetic testing to benefit family. Though I think it's important to note that genetic testing results, particularly for BRCA-related panels, have implications for immediate family members and beyond of either gender. And so this potentially indicates a gap in where we could get better at education. And we also looked at how many of these tested women had shared their test results with their immediate family members, including their daughters, sons, sisters, and brothers. We found a relatively high amount of test result sharing with daughters and sisters, and markedly lower test results sharing with sons and brothers. Again, getting at that point that we could do a better job educating folks that these test results can have implications for family members of all genders, and it's not necessarily just daughters or sisters that could benefit. And so again, thinking about that piece about we got us, thinking about how we can increase education and knowledge about genetics that my colleagues will continue to present on throughout the day is going to be deeply important to making sure that Black folks get the cancer care that they deserve. Next slide, please. And so just in summary, hope to have started out on a note of suggestion that genetic testing is increasingly important to guide breast cancer care. As we get better and better at treating breast cancer, genetic testing becomes more and more important. So getting folks tested and understanding the implications across family trees is deeply important for cancer care and also cancer prevention. I think that leads to the critical need to center the voices of and experiences of Black women in particular to eliminate health inequities. Thanks so much for your time today.
Wow, thank you. Thank you for that, Dr. Maya. We have a few moments for a few questions, if there are any. And while we're waiting for them to come in, oh yes, I see a hand raised. Monisha, is that your hand for a question or comment?
Yes, thank you so much, Dr. Maya. I'm curious about this because I did not have genetic testing before I was diagnosed. I was diagnosed for the first time in 2016. It wasn't until I was diagnosed the third time in 2021 that I was actually referred for genetic testing. And even though I was diagnosed first, my father was later diagnosed with prostate cancer. And so there are some studies that show there might be a connection between colon and prostate cancer and breast cancer. Again, something I didn't know. And so even though I was diagnosed first, I wondered, had I had that genetic testing, would I have been able to understand that relationship and that there might have been a genetic sort of predisposition for breast cancer?
Thank you so much for that question, Monisha, and for sharing your story and also for telling us a bit about your family. You know, one of the things that I frequently stop and reflect on is how much knowledge has changed between 2016 and now in 2023. And it's entirely possible that what was known at the time or what was recommended at the time is not where we are now. And so when I had shared that study that had indicated that Black women were previously had higher rates of BRCA mutations than previously thought. That study was published in 2016 or 2015. And so if you were initially diagnosed in 2016, I mean, our knowledge is still unfortunately catching up. And so it's one of those things where perhaps if you were equipped with that knowledge and we had the understanding that we do now, that could have potentially benefited. But you, to the point about your male relatives and family members, I mean, it's absolutely critical to talk about these issues with them as well, in particular, given the links with advanced prostate cancer potentially. And so I know sometimes, particularly in Black families, it can be hard to talk about these sorts of health issues with family members in general, and especially family members of the opposite gender. But the more information that we share about our personal health history with each other, the better all of our families will be.
Thank you.
I can really appreciate that question. I got tested for the first time in 2014. So I have family history of ovarian cancer in my mother and breast cancer, my grandmother. And the first time they told me I was only eligible for 2 of the genes, the BRCA1 and 2. Years later, I became eligible for more panel testing, right? About 48 other genes in addition to those 2 genes. And I think it's really important for physicians, especially clinicians, to make sure that we not only offer that testing, but offer what we call update testing, right? The knowledge that we have about genes can change. And as it changes and as it grows, so too must the testing landscape. And so it's important, I think, to talk to your doctors about that. If you had testing for just the 2 genes, are there others? That we know that there are other genes like PALB2 and ATM, and, P53. There are so many gatekeeper genes that we can look at to see, what runs in those families. But it worries us when we don't know that family history, because how many of us, right, would benefit from more testing or benefit from additional screening if we knew what that family history was, even in the absence of a mutation. We have one more question here in the chat, Dr. Maya, and it says, if you weren't diagnosed but you had genetic testing and you have a family history, what are the thoughts on measures like mastectomies, even without a cancer diagnosis?
I mean, I would say that would need to be a conversation with your personal medical provider. I certainly don't think that any of us on this panel could provide medical advice, can or should, quite honestly. And so I will defer that one, because I mean, that is a pretty monumentous decision that I would want to make sure is made with appropriate medical counsel.
Yeah, and what I can say is that there are risk calculators now. We can plug in your family history and see what is the percentage of your risk and help you to decide from there. So I run a high risk program at my hospital, and we see patients who have high risk but don't have mutations. And so what percentage of risk is acceptable before a double mastectomy becomes an option? And it is a very, very personal and personalized conversation. Dr. Maya is right. This is something that you want to talk about with your doctor. We have another question. We got a hand raised. Sora Stacy Tate Wolf is joining us today. How you doing?
Good. How are you?
Man,
Wonderful presentation. I really appreciate it. Dr. Maya had a comment that I just want to reaffirm something that you said in terms of genetic testing, because I was diagnosed in 2005 and recommended for genetic testing for BRCA1 and 2, and I did not have it. But I was diagnosed with DCIS, so I had a bilaterosectomy with reconstruction. And before that, my mom, her 2 sisters, and my grandmother all had breast cancer. So it's very relevant in my family. And we I was constantly doing mammograms as a result, found it early, but it came back into last year. And the year before that, 2 years ago, I did genetic testing again for 35 genes versus the 2. And they didn't find anything. And it was reiterated to me through my medical oncologist that most likely they don't have found the gene for you yet, because that gene pool is not as widespread as it should be. And in that 3 years time, my father was then diagnosed with advanced stage prostate cancer, and he had genetic testing as well, and was nothing, he had no connected genes at that time either. But it's definitely, I was told to go back in 5 or 10 years to get genetic testing again, just as things progress, to see where things go, because they haven't found the gene yet that gene pool for people of color, most likely because the pool is small.
Thank you so much for sharing your story. And I think I greatly value that, because I think it connects to where I had started, to where I had ended, from how because how we conduct cancer research is structurally racist, because society is structurally racist, that then goes on to have deep implications, like potentially what you're talking about, that we are constantly playing catch up to make sure that we're having diverse enough pools, genetic and genomic pools, to develop appropriate tools and tests for patients of color, and specifically Black patients. So thank you so much, Stacey, for sharing your story with us.
Doc, I got one last question. There are resources in the chat provided by Vassar, which is a center that specializes in hereditary cancer mutations, particularly BRCA1 and 2. And my question for you was about folks who are worried about genetic testing. They're worried about safety of their genetic information. They're worried about trials and experimentation. What do you say to people who may have reservations about some of those things?
Thanks for that question, Dr. Moreau. I mean, I will start by saying I hear y'all. I myself am concerned about where my own information is going. And I think there are certainly resources out there that can help you identify which sorts of tests are legitimate and better than others. For example, the sorts of health tests that you might be able to get from entities like 23andMe and Ancestry.com have started dabbling in cancer genetic testing. That is not the same test as what you get from your doctor. And in those cases, because those are private for-profit entities, your information could go wherever. And so an organization that comes to mind is FORCE, Facing Our Cancer Risk, that provides really great resources for thinking about ways that you can safely get genetic testing, that really thinks a lot about these privacy related issues, and you can have a better idea of where your genetic information is going. And two, I'll just close by saying that if you're talking with a medical provider about these sorts of things, ask where you are being seen for care, what is being done with this information. They have an obligation to answer these questions for you, and should be in support of helping you make the decision that's right for you, and making sure that you provide the appropriate consent processes for what data you want shared or not shared.
Absolutely. And I see Laura put in the chat that there is legislation that protects your hereditary or genetic mutation, especially from being used against you. But you do want to ask about, where that information gets stored, who has access to it, and how it's being used outside of your own health benefits and purposes. We have a comment in the chat, and I think that, do we want to have this conversation now, or can we push that a little bit later on, Laura, about the financial implications and sort of the lifestyle and insurance discussion? Because I think that could be a broad discussion, can't it?
I think it could, and that's why state by state, it's really important for you to advocate your legislators to protect your data. Maryland has a bill, for example, to prevent life insurance companies from considering genetic testing results in underwriting your care. But in general, advanced care planning is something that we advocate for breast cancer patients.
Absolutely. And so, Nicole, did you want to say a few words really briefly about that? Okay. Well, we can save that commentary for the end.
I'm sorry.
Oh, go ahead.
Yeah, I wasn't sure how to unmute myself. Laura pretty much said it best. As a financial advisor, I think it's really important as I see clients who haven't sort of thought about that financial planning piece, and we don't want your medical history or potential for life incidents to happen that would prevent you from being able to have additional resources in caring for yourself while you're living, or caring for your dependents and beneficiaries should you pass. So just wanted to make sure to make that point.
Thank you for that. And it sounds like in our chat here, we're talking about bringing you back to really get into this in more detail with us and discuss the financial impacts of cancer care, family planning, all the considerations, because it's something that you don't know until you're right in it. And we should be thinking about these things in advance for our families. So we've covered some of the history, the historical reason for why this is important, the testing, who's getting it, who's not getting it. And I think it's great now to talk about the lived experience. Once you pursue testing, what happens if a mutation is identified? How do you advocate for yourself? How do you use this information to make important decisions for you and for your family? So we are so thrilled to have Ashley Dedmon with us today. She is a trained scientific cancer advocate. She is with the Vassar Center, and she is a member of their BRCA association. She is a BRCA2 mutation carrier, and she is a breast health leader. She's an author, a speaker, and she's everywhere that I am, and I love it because we just keep tag teaming on these Zooms and in real life, where she's talking about the importance of genetic testing in their practices, and for other healthcare professionals, the importance of screening for family history. She is a 2022 National Breast Cancer Coalition Project Lead graduate. She's a research advocate with Houston Methodist Research Institute, with the NCI Patient Advocate Work Group, and most recently she's the CDC Advisory Committee on Breast Cancer in Young Women, where she co-chairs the Genetic and Genomic Working Group. She's a member of the NCI, a member of the National Institutes of Health Physical Sciences Oncology Advocacy Network, the National Breast Cancer Coalition, Penn Medicine Vassar Center for BRCA Young Leadership Council, the Black and BRCA Initiative, and she's a previvor. She was a teen caregiver of 2 parents with cancer, and during her double mastectomy journey, she authored a book called The Big Discovery, which is a children's book that facilitates and guides families through a breast cancer diagnosis. She's been seen on TED Platform, Women's Health Magazine, Healthy Women, Essence, other media, but her greatest accomplishment is being a wife to her husband for 8 years, a mother to their children, and when she's not working, she loves to spend time with that beautiful family, and she loves to work out and spin. Ms. Ashley Dedmon, how you doing today?
I'm doing good, Dr. Mo, doing good. Blessed to see another day. Blessed to see another day.
Absolutely, and we are just, so we have a question and a poll for the audience. So, have you had genetic testing? And the questions are, have you documented your family history? Do you know what it is? Yes, no, I don't know. Your knowledge of genetic testing. Do you have a high level, moderate, low, or genetic testing? What's that? Maybe you just tuned in and you're playing catch up. We're going to ask you to submit those poll questions, and we'll circle back with some data. In the meantime, I definitely want to get into this. Let's talk about the generational impact, Ashley.
Absolutely. Thank you. So thank you, Dr. Mo. So I'm going to be speaking today from the generational impact of cancer, of breast cancer, not just the physical aspect, but the mental and emotional aspect that I experienced from both of my parents, but also that I experienced as a teen caregiver, as a young woman, young adult, because this disease impacts has a generational impact physically, mentally, and emotionally. And I think some of my fonts didn't carry over, but that's okay. We're going to keep it moving. But what you see here before, and I'm actually going to talk through my journey, a portion through storytelling, and then the last portion just through actually talking through my family history. But what you see here is not a complex equation. It is not a mathematical code. However, it is a code. It's a very special code. It's a very unique code. And this code did three specific things. It educated me, equipped me, and empowered me to make informed decisions about my health. This code right here is my actual BRCA2 DNA sequence. So when I received my results, I was tested through Myriad. This is what they sent me back. And so 1538DEL4 is a code that forever changed my life. Next slide, please. And so I'm going to talk to you, like I said, again, about the mental, emotional, and physical impact of my parents' journey in a teen caregiver of two parents. And there were a lot of feelings and emotions that I felt when my mother passed away from metastatic breast cancer. And one of them was hatred. I hated her. For the first time in my life, I hated my mother. I wondered if she loved me, if she cared about me, if she wanted to see me grow up, get married, and become a wife of my own. My mom cared. I know my mom cared, but she forgot. She forgot about her health. Because being a wife came first, being a mom came first, work came first. But what should have also come first was her health. Scheduled mammograms and well-woman exams got rescheduled because life got in the way. And ultimately, she got away. We were on vacation and we were going into our hotel room, and my mom fell and tripped going into our hotel room. And so when we got back home, she was complaining of back pain. So we took her to the emergency room. And that emergency room visit resulted in a stage 4 or metastatic breast cancer diagnosis. I remember the day the doctor told my dad. He was very arrogant, very nonchalant, because to that particular doctor, she was just another patient. He walked in and said, "Your wife has 6 months to live," and he walked off. Again, because to him, she was just another patient. But to us, she was a wife, she was a mom, she was the heartbeat of our home. And at the age of 18, in the waiting room, hearing this information, overhearing this information, I knew something was wrong. I knew our life was about to change. I remember hearing a thump on the wall, and my dad's head hit the wall, and as he was crying, he slid down the wall crying out for his wife. Over the course of the next 4 years, she and my dad traveled, went to 4 different comprehensive cancer centers. No one talked to my mother about genetic testing. No one asked her about her family history. She underwent hormone therapy, chemo, and radiation. They also traveled to a couple of cancer centers throughout the United States looking for answers to questions that they had had. And I remember the morning my mother passed away, my dad called me and told me to get to the hospital. And I got there
And I saw my mother in ICU, and I saw my dad in the corner crying out for them to save her. And I remember a conversation that my mom and I had had earlier, maybe about 2 or 3 days earlier, coming home from treatment. She said, we got home and she said, baby, mama's tired. And I said, okay, mom, let's get in the house. I'll get you set up like I usually do. And she looked at me and she said, Ash Bash, no, not that kind of tired. And I knew then it wouldn't be long. And so remembering that, having recalled that while at the hospital, I went to my dad and I said, Dad, this is not what she would have wanted. We've got to let her go. And he said, Ashley, you don't know what you're asking me to do. And so we talked and we prayed and we talked and we prayed and we finally made our decision. And so we went into ICU and we hugged her, we loved on her, we kissed her. And we told her she had fought her fight, she had kept her faith, and that her race was done. And I went over to her bedside and I said, Mama, your baby girl's gonna be okay. She kind of gave me a little side smile. And then shortly after, she took her last breath. And so a couple of weeks later, I was about to graduate from college and we were preparing for arrangements for my mom. And my dad, while I was at school, my dad had called me and he had said, Ashley, Dad has prostate cancer. And I remember asking myself, what is going on in my family? Next slide, please. I knew I needed to educate myself. I knew I had questions. I knew I needed answers. Next slide, please. I knew that my mother had just passed from metastatic breast cancer. I knew that my great-grandmother had breast cancer. And my dad, after my mother passed, had informed me that my great-great-grandmother also had breast cancer. And so now my father has prostate cancer. Next slide, please. So I had questions. What do I do? Is cancer coming for me? Am I going to die? What is going on in my family? I had questions. I knew I needed answers. So I reached out to my OBGYN. I updated her on my family history. And I also informed her of my father's recent diagnosis because our family health history can change each year. And so she talked to me about genetic testing. And it was so much. I had just lost my mom. I was just found out about my dad. I was trying to graduate from college. And I knew I had to take a new path. I knew I could not go back to the path of the unknown. I knew that genetic testing would give me answers. And so I needed to take a new path. So I decided to equip myself. Next slide, please. Next slide. So I underwent genetic testing and counseling, and I found out that I am the carrier of the BRCA2 gene mutation. And so this is what I learned throughout my journey. BRCA stands for breast cancer genes. Everyone has a BRCA1 and BRCA2 gene. BRCA genes do not cause cancer. They help to prevent us from getting cancer. The BRCA mutations occur when the DNA that makes up the gene becomes damaged in some way. Both men and women can have a BRCA mutation because we all carry the BRCA1 and 2 genes. BRCA mutations can be passed or inherited and passed on to children. BRCA mutations have been found to increase a person's risk of developing breast cancer and ovarian cancer, as well as elevated risk of other cancers. So this is what I learned throughout my journey to really help me to understand what it means to carry this mutation. But I also had to learn about how I could protect my health going forward. And so my OBGYN told me that I needed to start seeing a high risk oncologist to manage my breast and ovarian health going forward. And so I went to meet with my high-risk oncologist for the very first time, and I walked in and I walked out. I was very angry. I was in denial. I was frustrated. And going into an oncologist's office reminded me of the trauma and the triggers of, it triggered me, from the times I would go to treatment with my mom and just seeing her lose her life. And so I walked in and I walked out and said, this is not for me. And so a couple of days later, I was in Walmart and I just kind of felt this tap on my shoulder. And I knew it was God saying, you need to go back. And I was like, no, I'm not going back. I'm done. And so, of course, a couple of days later, God again saying, you need to go back. And so I was obedient and I did. And I went back and I talked with my high-risk oncologist. She really got to know me. We spent about an hour talking about me. We had great bi-directional conversations. I was unmarried, no children. I was dating at the time. And so she was very aggressive. And she told me that she had to be aggressive because I had options and she wanted me to explore those options, and that my mom didn't have options and that some of her other patients don't have options. And so we explored my risk management options, and she shared with me about increased screening or surveillance. She talked to me about hormone therapy, sometimes referred as chemo prevention. And she also talked to me about risk reducing surgery, sometimes referred to as prophylactic procedures. And so for me, at the age of 21, I decided to undergo risk management options. I felt empowered by my decision. I knew that I made the best decisions to aggressively monitor my breast and ovarian health. And I did that for about a decade. And during that time, I met my husband, I got married, we had children, but I saw myself going down the same patterns as my mom. And that was putting everything and everyone ahead of my health. But this time I knew better. I knew my risk for breast cancer. I knew that my risks were above the average woman that's at a 12 to 13% risk over her lifetime. So I knew I needed a new course of action. And so I reached back out to my my high-risk oncologist to explore other options. And in December of 2016, I had a bilateral prophylactic double mastectomy, or a preventative double mastectomy, to drastically reduce my risk of breast cancer. Next slide, please. Breast cancer aggressively attacked 3 generations of women in my family. But through genetic testing and genetic counseling, my girls and I can aggressively and preemptively attack breast cancer. Undergoing genetic testing changed the trajectory of my standard of care. My standard of care looks different. It also has helped me to become a better advocate as I am navigating through the health system. And before I transition into the last part, I didn't hate my mom. I loved my mom, but I was a teenager at the time, and life was all about me, right? You know, nothing can ever happen to mom, right? Mom is always going to be here, right? I believe a mom would truly give her life for her children. If my mom knew that she had to sacrifice her life so that I could live and her 2 beautiful baby girls could live, I believe she would do it again, because that's what moms do. This disease impacts us all at different times and in different ways, mentally, physically, and emotionally. And I challenge you today to know your family history, educate, equip, and empower yourself on your personal and your family health history. Talk to your doctors, demand for genetic testing, talk to them about it. If you know that you have a family history, it's okay to push back. It's okay to ask why. And finally, make your health a priority. Next slide, please. And so I'm going to talk to you just now as far as my daughters. My daughters have a 50% chance of having inherited my mutation. And so I look at their prevention care starts now. I educate my girls very early about their body awareness. I talk to them beginning at the age of 7 about their family history and my BRCA mutation. I advocate, talk with them about monthly self-breast exams and just being aware of their body. And then as they get older, my job is to equip them with in-depth knowledge about their family history and genetic testing. And then as they get older, 15 to 18, it's really having them to begin to think about genetic testing and counseling. They can't get tested now because there's no guidelines. There's no preventative guidelines for their age now. And then finally, as they grow into young adults, I want them to be able to make informed decisions. I have also, in my family planning with my husband and I have put my BRCA mutation results from Myriad in my will, in my legal documents, because if something were to happen to me today, they may not remember, but that is documented in our legal will and trust that I carry this mutation, so that they have this information and they can easily navigate the system as they get older. Next slide, please. So who did I inherit my mutation from? I shared with you, I had 3 generations of family history on my maternal side, on my mother's side. But my dad is a prostate cancer survivor, and carrying a BRCA mutation is linked to prostate cancer. And so in February of 2021, my father got genetic testing. Next slide, please. And he was negative. I did inherit, and I can conclude and confirm that I inherited my mutation from my mother. And again, the status of my daughter's results are unknown because they cannot get tested at this age. Next slide, please. Again, this is just a quick overview of family history, the ages that my grandmother, great-grandmother, grandmother, and mothers were when they were diagnosed, my father's diagnosis. Next slide, please. I love this because, my standard of care is different. So when knowing I carry my mutation, I use this as my VIP card as I'm navigating throughout the medical system. If I call and I'm trying to get screening and someone's like, oh, you're too young, or oh, you don't need this, I always say, I'm BRCA2 positive. I lead with that. That is my VIP card. That's my get in the door card. That is my don't mess with me card, because I know what I'm doing. I know what I'm talking about. And knowing that I carry this mutation, knowing that I am high risk, helps me to navigate my standard of care better. And it also makes those medical professionals that I'm working with understand that, that my standard of care looks different. Next slide, please. Again, this is kind of my risk management plan. I know I talked through it. Currently, I'm done having children, so I still receive transvaginal ultrasounds to monitor my ovarian health. I receive CA-125 blood tests to monitor my also for my ovarian tracking and testing and risk management as well. And then seeing a dermatologist biannually for melanoma. And then when I get closer to my 40s, I will consider a salpingo oophorectomy. But now I just see an oncologist, gynecologist. Next slide, please. And just a couple of things, as someone that's in this space that has a passion for this work, I'm constantly staying abreast of the disparities in genetic testing. I won't get too much into it. I know my two fellow panelists have talked about it and will continue to talk about it, but it's something that's near and dear to my heart. Next slide, please. And I'm just, as I close out, it's important that I'm empowering myself, and I just do that. Next slide, please. Just through continuous education of this work, working with nonprofit organizations in this space to continue to get the word out and advocate about the importance of genetic testing and counseling, especially in populations of color, in the Black community, because our genes matter. And I'm just so excited to be a part of this today with Touch for Life, because our genes matter, our generations matter, our lineage matters. And as a daughter of a mother who was diagnosed and lost her life, I cannot let her death be in vain. And so that is why I'm so passionate about the importance of this, of tackling this horrific disease, but this very unique gift that I call genetic testing that can help to save, that I believe will help to save generations to come or make them aware. And that's it. Happy to answer any questions.
Wow. Well, first of all, thank you. Thank you for sharing not only your experience, but what you learned from it, the thought process, the very deliberate way in which you now approach not only your health, but the entire family's health, right? Your generations. It's so powerful. And it's an important example of what we can do with this information, right? Everybody wants to know their ancestry and their genes. Everybody wants to know, but then what are you going to do? And this is such a wonderful example because, and I want to say it's not an easy journey, and it's not to be, taken lightly in the sense that this is a whole path I think you never thought your life would take, but clearly it's the one that was meant for you.
Yes.
Wow.
I always say my mother made the sacrifice, and I have to carry it out. I can't let it be in vain.
All right, so we've got a raised hand. We got some questions in the chat. Let's start with that raised hand. I am unable to see it on my screen, but I understand that it is there. Oh, there we go. Angela Braid, please share with us. You're on mute.
I just wanted to say thank you so very much. I learned a great deal from you, all the speakers so far, but really took away the will and testament and how we change it for our children. I too, I had a negative BRCA gene and then had to go for additional gene count testing. So I love the fact that you have your number, your code, and I just thank you for sharing. It was powerful.
Thank you, Angela. Thank you.
And I've looked your book up already on Amazon. I just didn't want to put it in the chat.
Thank you.
Please do put the link in the chat, and in the chat you will also find some additional resources. Touch for Life has some programs and resources to get free testing. It used to be that this testing was cost prohibitive for women, and even in the community where I practice, they only allowed women who had already had a cancer diagnosis to get that testing, and if you had a family history, they didn't have a program for you. And so it's really important that you find the high-risk programs and that you get screened and that you go over that family history again and again and again, because as Ashley said, that family history can change. We have also in the chat advocacy testing questions to ask your doctor, right? So what should you ask your doctor about genetic testing? And Laura's put some resources in the chat for that. Ashley, I have a question for you. What would you say to people who are risk averse, and they say, well, you know what, if the train's coming, I don't want to see it coming, and maybe I don't want to get tested because, for whatever the reasons or the fear is, how do you talk people around and through that fear?
Absolutely. I think the first thing is to realize fear is real. It is a real feeling and emotion. And I think we all experience fear from just different things. And so genetic testing is definitely a personal decision. It's a personal decision. I'm not a doctor, I'm not a genetic counselor, but I look at it like if you carry the mutation, it's there. The question is whether you know about it or not. And if you know about it, you can, and I think it looks different when a person is diagnosed and undiagnosed. I have to say that because it does. I think from the undiagnosed perspective, it really gives you options. And if I had to, and I'm speaking as a daughter, and then I'm going to speak as a mom. As a daughter, my mom, there was nothing my mom could do to keep me from inheriting this mutation. It was not her fault. She, I even sometimes as a mom think I can't feel guilty for something I cannot control. It's a fact. I carry this mutation, and there's a risk that one of my daughters, both or none, may or may not inherit it. But I think it's just the knowledge of knowing. And then if you know, then you can preemptively do something to reduce your risk. I also say too, personally, you may not want to know, but if you have children and grandchildren and great-grandchildren, that's valuable information that you could attain through yourself to help the generations to not have to go through or be impacted from a diagnosis if you were to find out. But again, it's a personal decision, because with any information that you receive, there's a lot of options and a lot of decisions you have to make. So I just say continue to have conversations with family members, with your doctors, prayer, whatever you may use to help you find peace in making a decision. But just know that genetic testing is, as I say, is a generational gift to pass down. Because again, this disease, if you look at it, impacted 3 generations of women in my family. I look at that pivotal moment that shifted the trajectory of this disease, that it does not have to have the same impact going forward.
Wow, there it is, right? That's the power. That's the reclaiming your power part of it, is that, you know what, this has affected and impacted us, and now we can do something about it to reduce that risk. So that's huge. I want to allow our next speaker to have enough time to share. And so you all are in for a treat, right? Because what we've talked about is sort of the history, the landscape of testing, the lived experience of someone who has gotten tested and taken the necessary steps to reduce that risk. But now what about the implications for treatment? So I'm a breast cancer surgeon, and I test my patients so that we can make decisions about what surgery they're going to have, so that we can talk about what treatment options might be best for them. But prior to, I'm going to say within even the last 10 years, we have really started to unravel the mystery that there might be implications for treatments, for medical therapies based upon these mutations, and that we don't need to look at this as an afterthought. This is a before thought, and it's an upfront thought in the treatment plan for cancer patients. So it is my privilege to introduce Joannie Ivory. Dr. Ivory is the Chief Fellow in Hematology and Oncology at the University of North Carolina at Chapel Hill. She is currently a 3rd-year fellow and an NRSA postdoctoral fellow at the Cecil G. Sheps Center for Health Services Research. She's originally from New Orleans and attended Xavier University of Louisiana, graduating summa cum laude with a Bachelor of Science, and then she went on to receive her doctorate from Meharry Medical College. Her research interests include addressing disparities in breast cancer mortality and improving diversity in clinical trial participation. And most recently, she was awarded the 2022 ASCO Conquer Cancer Foundation Young Investigator Award for Diversity and Inclusion in Breast Cancer, and the UNC Lineberger Innovation Award to fund research investigating the relationship between race, age, molecular subtypes of breast cancer, and its effect on treatment decisions. So it is without delay and with great pleasure that I introduce Dr. Joannie Ivory, who will be presenting the treatment implications of genetic testing. Welcome, Doc.
Thank you, Dr. Gary. Appreciate it. All right, next slide. All right, next slide, please. Okay, so these are some of the objectives I'll be discussing today, including genetic testing and breast cancer in general, some of the indications for genetic testing, as well as treatment implications. And then I'm going to just tie in the importance of clinical trials. Next slide. So when we're talking about genetic testing and breast cancer, what I first want to point out is that approximately 5 to 10% of breast cancers are inheritable. And of these 5 to 10% of breast cancers, BRCA1 and BRCA2 are the most common mutations that we see. However, there are other genes that increase the risk of breast cancer, such as POLB2, CHEK2, as well as TP53. So these are some that you may or may have not heard of. And so when you're considering genetic testing, I want you all to know that genetic testing should be done by a trained professional. And that professional can be a genetic counselor, a geneticist, as well as your medical oncologist, or even your surgical oncologist. And then there's 3 steps that are usually involved in genetic testing, which includes pre-test counseling, where we consider whether, we talk about whether or not your insurance will cover it and potential cost implications. We also get a detailed family history and also discuss with our patients, like what type of implications it can have as far as you discovering your risk of breast cancer and how you can share this information with your family. And then also we want to consider which type of test to order. Because in the past, we used to do single gene panels, which only looked at the BRCA1 or BRCA2 mutations, but now they have multi-gene panels, which look at a variety over 30 plus different genes. And so the last step for genetic testing is post-test counseling when the results come in. And so what can happen is that if we can identify different types of mutations, they will say pathogenic, which means associated with increased risk of disease, or it can be likely pathogenic. But something else you can also see is something called variants of unknown significance. And what that means is just that we've identified these variations in your genes, but we're just not sure of the risk that it poses on you getting breast cancer. So next slide, please. Now, next slide. Keep going, please, until it just, okay, keep going, keep going, keep going. All right. So before we kind of get into the nitty gritty, I wanted to just take us back to the basis as far as our genetic material that we received from our mom and father. Let's talk about DNA. And so when it comes to DNA, you'll see those 2 ribbon-like structures there that are light blue. These are the genetic material that you get from your parents, right? And so these are linked together through nucleic acids, and there's 4 of them: adenine, thymine, guanine, as well as cytosine. And so usually in our normal DNA, we want the A to go to the T and the C to go to, the G to go to the C. So what will happen as far as a DNA mutation is that, say for instance, you have an A that goes to a G. And as you see here, it's not supposed to go to a G normally, it's supposed to go to the T. So what this DNA mutation will end up resulting in is an abnormal protein. And so these abnormal proteins can be your BRCA1. The BRCA1 can become abnormal, or the TP53. And so let's take, for example, TP53 that I mentioned earlier. It's a tumor suppressor gene, which is supposed to stop your cells from growing usually. So if you develop a mutation in that gene, then it won't stop the cells from growing as usual. And then the cells will just keep growing and growing and growing. And then that's how cancer develops. Next slide, please. So what ends up happening, we have 2 different types of mutations. We have somatic mutations. And so those are mutations that can occur in the tumor cells themselves. And we don't actually pass these mutations on to our children. But then there's also germline mutations that occur in our eggs and as well as in sperm of men. And what ends up happening is if the mutation occurs in those, in the egg or the sperm, you have a 50% chance of passing it on to your child. So those are the germline mutations. And so as part of this talk, I'm going to talk about the germline mutations such as BRCA1, BRCA2, but then in the end, I want to kind of talk about the importance of some of the somatic mutations as well. Next slide. So these are some of the risks and benefits of genetic testing, or pros and cons. On the left here, we'll start with some of the risk. And I think we mentioned this before, the psychological distress of just kind of getting this information and knowing about your increased risk of getting breast cancer. In addition, some gene panels might find mutations that we don't know anything about yet, right? So we might find these variants of unknown significance, but meaning that we don't know if they're associated with increased cancer risk. And so we don't really use these type of variants to make medical decisions. And then also you may identify a mutation in a high-risk gene, even though you don't have a family. Say for instance, I've been diagnosed with a high-risk gene, but I have no family history of breast cancer. And so what ends up happening is that if you do get identified with a high-risk gene, you can possibly get more aggressive treatment based on having that gene versus if you did not have it. And then some of the pros of genetic testing is that you can become more informed. You can become empowered with this information. It can allow you to do preventive measures, and I'll talk about that a little bit later. It can help us tailor treatment options. And so there's actually targeted agents that pretty much target the BRCA1 and BRCA2 genes, as well as POLB2. And what this can translate to is into individuals living longer, because the more treatment options or the more that we can do to attack the cancer or stop it from coming back, the longer people can live. And then it can allow you to educate family members about their potential risk, and they can go and seek genetic testing as well. Next slide, please. So these are some of the indications for genetic testing based on NCCN most recent guidelines. And I think some of these have been mentioned before. And one is that if you're young or age less than or equal to 50 years old, we do genetic testing in people who have triple negative breast cancer, which tends to be one of the most aggressive subtypes of breast cancer. In people who have multiple primary breast cancers, for instance, if you have breast cancer in the right breast and the left breast, that's what we mean by that. Also, there's certain pathologic types, for instance, lobular cancer. And this is just, when we say lobular, is that the pathologist will give us the report and we can see if it's ductal versus lobular. So if it's lobular and the person has a family history of diffuse gastric cancer, then that's a reason. We also do genetic testing in men who have breast cancer. Also, if you have metastatic breast cancer, and then genetic testing can possibly alter your treatment decisions, we will do genetic testing as well. Because what can happen is that if a woman is being treated for her stage 4 metastatic breast cancer, and then we discover she also has a BRCA1 or 2 gene, then we can actually have another treatment option for her if she was to progress on her current medication. Then we also do genetic testing in people who have high risk disease. For instance, if you have multiple positive lymph nodes, or if you underwent treatment with chemotherapy before surgery, and then they did surgery and they realized that they still had some residual disease in it, then you may be a candidate for some treatment after that. Or if you have 2 or more relatives who have either had breast cancer or prostate cancer. And so this is not an all-inclusive list, but this is most of the indications. And then there's also some other indications where they say we can consider it genetic testing in our individuals. Next slide, please. So these are some of the treatment, or should I say management implications as far as genetic testing. If a pathogenic variant is found, what this could mean, and I think Ashley hinted on this earlier, is that we can do earlier screenings. And so we can, what ends up happening if someone in your family gets diagnosed with a BRCA1 gene, or they have kids, then we actually, you educate your children about becoming more breast aware earlier. You can start doing, you have clinical breast exams done as well as screening mammograms and breast MRIs. And these can start in your early 20s. Then you can also talk to your providers about doing risk reduction procedures such as mastectomies, as well as getting your fallopian tubes and ovaries removed. You have an informed decision with your provider, because you want to make sure people have done meaningful things to them in their lives before you consider this life-altering procedure, such as making sure people are done with childbearing before they consider this. And then there are also some things you can do outside of surgery, such as risk reduction agents, like tamoxifen and raloxifene. And so this is a pill that's taken once a day, and you can take it for about 5 years. And this is pretty much reduces your risk of breast cancer if you have the BRCA1 gene. And then there are also targeted therapies that have been approved in women who've been diagnosed with breast cancer and have a BRCA1 gene, such as a BRCA1 or BRCA2 gene. And this medication is called olaparib, which is also Lynparza. That's the brand name. And then there's some clinical trials that if a person get a genetic testing and they're found to have a particular gene, they may become eligible for a clinical trial based on the presence of that gene. All right. So now I'm talking about clinical trials. I kind of want to just transition into talking about the importance of equitable clinical trial participation, because that's my passion. So the importance of clinical trials, we all know that it's important for us to develop new drugs and improve patient outcomes, right? They help us determine the dose of our medications, as well as the safety profile, and if these drugs work. And ultimately what this can translate to is enhance and prolong life for people. And so it leads to scientific discoveries, such as just last year, trastuzumab deruxtecan was actually approved for women who had HER2 low metastatic breast cancer. And even in lung cancer, there's a certain targeted mutations that we can attack with certain drugs to treat metastatic lung cancer. Now, one of the biggest problems is that overall, we have a low percentage of of people with cancer participating in clinical trials, but even lower proportion of racial and ethnic minorities in these clinical trials. So we're not really well represented in clinical trials. And so with this becomes a problem, because then we want to say, like, is this information really generalizable to our population, right? So next slide. And the reason why this is important, because, drugs, they get approved through clinical trials pretty much, right? We test the safety, the efficacy, and this is how the FDA approved them for the market. And so as you can see here, this was a clinical trial called Olympia. And this is how olaparib or Lynparza got approved for women who had BRCA1 and BRCA2 mutated breast cancer. And so what they did was they treated the women, they ended up getting their chemotherapy. And then after they got their chemotherapy, they randomized the women to either get olaparib or to get placebo, right? And then they did it for a year, and they followed the women for 3 years pretty much. And what they saw is that the women who actually got olaparib did much better. They survived longer, they had better progression-free survival. And so this is when this got approved for women who had BRCA1 and BRCA2 mutated breast cancer in early stage. So it's actually approved in early stage as well as metastatic breast cancer as well. Next slide. But now I want to just talk about some emergent studies too, that just shows the importance of other types of genes in us as well. So at the University of North Carolina, we're actually doing a clinical trial called Harmony, which means harnessing your analysis RNA expression and molecular subtype to optimize novel therapy. Next slide. And so what we're pretty much doing is that we're analyzing the tumors of our patients with newly diagnosed metastatic breast cancer. And through this RNA analysis, we're looking at 50 genes to pretty much categorize these tumors as into these molecular subtypes of breast cancer, which you may or may not have heard of. And so there's 4 different types of molecular subtypes of breast cancer. There's luminal A, luminal B, HER2, enriched, as well as basal-like, which is equivalent to triple negative. It behaves like triple negative, okay? And so in the patients who have luminal A molecular subtypes, we know that these tumors are actually more susceptible to endocrine-based therapy. And the tumors that are basal-like, we know that they tend to be more resistant to endocrine therapy, but they respond more better to chemotherapy. And the reason why this is important, I just kind of want to point out, these molecular subtypes are all in hormone receptor positive, HER2 negative. And so we have different types of molecular subtypes within the hormone receptor positive types of breast cancer, right? Next slide. And so what a previous study has shown, called the Carolina Breast Cancer Study, what it pretty much showed is that what we saw in Black women as well as younger women is that they had a lower frequency of luminal A tumors, right? So these luminal A tumors, recall that I said that they are more susceptible to endocrine therapy. Well, we saw that they were less common in Black women, they were less common in women less than 50 years old. And we also saw that Black women and younger women had higher risk of recurrence scores as well. So we knew that this was the case, but we only knew that this was true for early stage breast cancer, which is stage 1 through 3, okay? We didn't know whether or not this would be the case in metastatic breast cancer. So that's what I decided to look at in the next slide. So as part of a study right now that I'm currently doing the analysis for, we pretty much want to see if the relationship with these molecular subtypes of breast cancer, the same relationship as far as Black women having less frequency of luminal A and higher frequency of the basal-like molecular subtypes, if this same relationship is seen in hormone receptor positive, HER2 negative metastatic breast cancer. Because we knew it was true in early breast cancer, but we just don't know if it's true in metastatic breast cancer. And let me tell you why this is important. If we were to see that in metastatic breast cancer, Black women still have a higher frequency of the basal-like molecular subtypes, then what this could mean is that in this hormone receptor positive disease, these women may become more resistant to hormone-based therapy earlier, and they may benefit from chemotherapy-based regimens more earlier. And so this will actually become the basis for clinical trials in the future. If you can go to the next slide. If you can see here, there's a clinical trial right now going on called Harmonia, where they're actually starting to use these molecular subtypes of breast cancer to look at the difference in response to treatment. And so if you see here, we have Kisqalis as well as Ibrance. And what they're looking at, they're pretty much comparing the response to ribociclib and palbociclib in women who have HER2 enriched intrinsic subtype, right? But as part of this clinical trial, what they're also doing is that in the women who have basal-like molecular subtype, they're actually doing exploratory analysis, and they're randomizing women who have basal-like intrinsic subtype to receive chemotherapy. Because like I said before, what we saw is that the luminal A, the luminal B, they're more responsive to the endocrine therapy versus the basal-like. And so I think what will end up happening if the study shows that it's positive, you may start seeing in the future, we're actually starting to use this information to better tailor treatment decisions. I think my next slide is the references, and that's all. Thank you, everyone.
Wow. Well, let me just say, first of all, what you just heard really was a masterclass in understanding the molecular subtypes of breast cancer beyond ER/PR and HER2, which is something that I know many advocacy groups and survivors are really getting more acquainted with. When you ask somebody, what type of breast cancer did you have, you know that type is a bit more sophisticated than invasive ductal or lobular carcinoma. And so understanding those subtypes has implications for treatment. But what you may not have really understood today as much of is what she went over in terms of the luminal A, luminal B subtypes and why that matters. And I think and I hope that we'll have you come back and talk a little bit more about that nomenclature, why that's important, even in the genomic testing landscape, right? The oncotypes and the mammoprints and all the tumor testing. That stuff has implications for tumor testing, and it's really important. So Dr. Joannie, thank you for that. And yeah, we are fortunate to have someone that looks like us in this scientific space. That's a comment in the chat, Doc. We have a question really quickly from Monique Jackson.
Yeah, just so fascinating. Thank you so much. So I have metastatic disease. I am currently taking ribociclib, Kisqali, along with a hormone therapy. That one is for disease suppression, one is for, to reduce the amount of estrogen that I have because my particular strain is hormone receptor positive. Just, I think one of the things that's interesting about this is that the science is sort of rapidly changing, and that's something that Dr. Maya talked about. My concern, though, is when I look at how many people came to this presentation, this great content, experts, people who are clearly passionate and advocates. And what we say is we don't want women just to survive. We want them to thrive. And we know that Black women die disproportionately from this disease. Some of it is actually mentioned as people just not wanting to know. But how do we get this information out here? Like, how do we get people, because some of it might be that they're just intimidated. And I think Dr. Mo talked about the nomenclature, not understanding, like you said, what type of you have. They may not know that they're HR positive, they may not know what that is, triple negative. And so maybe that's the way we do it. But how do we get this to become a part of our vernacular where people understand these risks, they understand these different terms, and they're empowered when they go to their doctors to get the testing and understand what their risks are so they can make these decisions, right? Because I was already stage 4 before knowing all these other characteristics and what my risk really was. So thank you for that.
Yeah, I think platforms like this is a great way to get the information out. Like Dr. Gary said, I would love to come back and expand on this more and educate women. I also think just engaging as far as, I think it's a responsibility of us as clinicians as well to inform people, as well as like do some community engagement, actually talking to, working with patient advocates as well. I think those are ways, but I definitely think this is a platform where we can actually get some of this information out and be able to have the archives available for people who are not able to join with live. And also just working, Laura, I heard you say you're part of a sorority. You guys have an impact that reach across the country, across the world. And so, also just kind of collaborating with sororities as well can get this information out to our community. I think that's a powerful source. Even perhaps bringing this to the salons, or when they have beauty shows or something, perhaps we have a session there. But I think those are ways too, but you know, we try to get some of this information out at conferences, but I don't think we're reaching the individuals that we need to reach, at least not all of them. So I think that's some of the ways I think we can get the information out.
And I will say we are doing a Touch for Life, working with community organizations. D9, other organizations have requested us to present workshops. If anyone on this call wants us to have a workshop around these topics, you contact us at hello@touchforlife.org or lcrandon@touchforlife.org, and we'd be happy to come. We'd be happy to provide this video for you to replay if you have a meeting. We need to get the word out. And so certainly, if you've got community health fairs, we've got one coming up in Baltimore next month, and you need this information out, that's what we're here to do. And like we say in church, tell your neighbor, tell your neighbor left and right, that's what we do. And if you've got people who want to hear this message, we are happy to help support that.
You know, I think also the conferences, the big ones, right, where the advocacy groups come in large numbers, there's a platform for you to share your lived experience for your research. I know we did an entire day of Black Women Speaks, and you know, there are opportunities, I think, but also I believe there should be much more education geared toward advocates to disseminate back to their organizations, right? Like these are the types of workshops that I think can be really helpful to empower advocacy groups to then disseminate that information, Dr. Joannie. So when we talk about ASCO and SABCS, I think that we definitely want to make sure that, you know, we don't just preach to the choir of ourselves, you know, because we tend to stay in our silos, right? We got the docs in one silo and advocates in their track, and everybody's on a track. But those tracks have to converge as best as we can.
Absolutely. Absolutely.
Dr. Maya, would like for you to weigh in as well. How do we get the word out about this, you know?
I mean, I co-sign everything that's already been said, and just to expand on points about how critical and important it is for us as researchers, clinicians, what have you, to present and inform in non-traditional forms as well. Thinking about, or I guess non-traditional in the academic sense, thinking about the Facebook Live session that we did, Dr. Mo and Laura, with Ricky. I mean, academia doesn't care about Facebook Live, but that's a way to reach a lot of people, quite honestly. And so I think that we need to, quite honestly, like sometimes divorce our minds from what is quote unquote expected from us. Like, nobody is reading our papers as much as we would like them to do, or maybe some people are like a specific select number. And it's like, really, as was mentioned, like events like this, where we can like, okay, what do these papers mean? And so Facebook Live, Twitter, Instagram, like all of the things that academia doesn't care about are where the people are. And I really love some of the creative suggestions by Dr. Joannie and by you, Dr. Mo, about how do we reach folks. And so I just wanted to mention that kind of explicitly, that like academia wants us to talk about our work in a very narrow confines and reach very narrow audiences. And that's not what we're here for. And I'm just want to express gratitude to be in a space with other science communicators who value these sorts of audiences as much as I do, and to have this opportunity to be in community with y'all to share this information.
What I heard was an invitation to do more translation of hot topics in science. So I'll give you an example. There was an article that just came out that looked at radiation, right, in postmenopausal women over 65, and whether or not they might benefit if they had a favorable subtype. And you know, the trial, the data that just came out, but it's not extrapolatable to all groups and all people, right? And it's still optimizing treatment for people who have really optimal disease. And so everybody's talking about it. Oh, this means that people over 65 don't need radiation. It's up to us to help interpret that data for the right people and for the right patients and to our communities, because there can be a lot of miseducation as a result of hot things that come out in our own literature, right? But you got to look at those subgroups in the data, and somebody has to translate that. So I took that invitation, and I'm gonna take you up on that, Dr. Maya. We can get online anytime and talk about some of these things in ways that people can really understand, because that to me is part of, you too, Dr. Joannie, that's part of our calling, and our responsibility. You know, that's the service that we pay for having these degrees and being able to do this work, is to be able to share it with the folks who need it the most. So challenge accepted. Laura, I'm gonna put you on the spot and let you talk a little bit in closing. But I do want to mention that our upcoming next month, we're talking about sex. Let's talk about it. Sexual health, breast cancer, menopause, all the things. Please invite a friend. Please join us the fourth Saturday of every month as we are here, sisters. We're filling our souls, right? Soul filling our sisters, and with Touch for Life.
Thank you. Thank you, Dr. Mo, and thank you to Dr. Maya, Dr. Joannie, Ashley. It just really has exceeded my expectation of the information that we could provide, and all of you in your own rights are phenomenal women, as Dr. Angelou said, and we appreciate you sharing your gifts and your talent with this community to get the word out. I can't be more pleased. You made me cry, you made me laugh, you made me learn, and I hope that's the case for other people as well on this call. What we're going to do now is switch gears real quick. As you know, as part of SOS, we have giveaways, and we usually pick a random number of person on the out of the list to determine who actually gets these. And so beforehand, I picked the number at a random number, and that number is Camille Haylock. I don't know if you're on still. But the gift for this month is Together, our community cookbook. It's the cookbook that was produced with the help of the Duchess of Sussex, Meghan Markle. And so last month we talked about food, family, finding peace and fitness. And so you get a cookbook. That would be Camille. The next person who gets a one of these gifts. Oh, you'll also get a journal from Touch for Life to write down your thoughts. It's part of mental health, of course. And the next person who gets one is June Frisbee. You'll get this, and you'll get the Touch for Life notebook for this month. The way that you can redeem your prize is by emailing hello@touchforlife.org, so that we can get your address and get these gifts out to you, along with a few other little goodies. Thank you so much for joining us. Well, we want to make sure that, Dr. Mo, do I turn it back over to you to make sure that folks do the survey and
Okay, well, yes. So there is a survey. We want your feedback. We want to better understand what your needs are. And so we do have a survey for you. We're asking if you would be so kind as to fill that out. We want to certainly thank our sponsors. We want to thank Myriad Genetics, High Impact Partners, Whole Logic. We want to thank the Vassar Center for BRCA, our panelists, Ashley Dedmon, Dr. Joannie Ivory, Dr. Maya Roberson. This has been an amazing, amazing conversation. We hope that you will share it with your friends, with your colleagues, with your family members, share your church, your sorority, share it with strangers. And absolutely, and bring those questions back for us if you have them after watching this, things that you've heard, things you've seen, things you want Laura to cover in these sessions, because this is such a special and sacred time. So we have in the form, in the chat, we got the Google form here for your questionnaires and your survey. Give us your feedback. And Laura, I'm going to turn it over to you for final remarks. So just
okay,
thank you again.
Thank you so much, Dr. Mo, the incomparable Dr. Monique Gary. We couldn't do it without you. When the call went out that we wanted to do something for Black History Month, and we wanted to do something about genetics, this group volunteered to spend part of their Saturday with us. And so I'm very pleased with the information. You will get a recorded, this is recorded, and so there will be an email sent out with a recording of this that you can share with your community. And again, it's important to note that if you want us to come back or present and share this with your community, that we're available to do that as well. Thank you, and have a wonderful rest of your Saturday. And then if you're in the DC area, today we have a special treat. Nina McLemore Boutique in Chevy Chase, Maryland is doing a fundraiser for Touch for Life. So come get your fashion on, and part of your purchases will go to donate to support programming like this for Touch for Life. Thank you so much.